I want to go back to the biopsy question because that's a really very important component. And maybe I'll start the story with Amit, which is you have your patients in your clinic, hepatitis C, on what we call a screening program. And please tell us what the screening program is, and then tell us what might happen when something erupts in the liver. What do you do about it?
So anyone who has cirrhosis should be entered into an HCC screening program. The screening program should consist of at least an ultrasound done every 6 months. It can be supplemented with alpha-fetoprotein, which is a serum biomarker, to be done every 6 months as well. And that decision really depends, in my mind, in terms of the quality of your ultrasound. So although ultrasound can be efficacious when done by high-quality ultrasonographers, there's variability in terms of the ultrasound quality that you see in clinical practice. And so if you're not sure about the quality of your ultrasound, I think it should be ultrasound plus AFP. If you have good quality ultrasounds, then it can be ultrasound alone. But nonetheless, patients with cirrhosis should be entered into a screening program every 6 months. If they have any abnormality on the ultrasound, so a lesion greater than 1 centimeter, or an elevated alpha-fetoprotein greater than 20 nanograms per milliliter, then they should be going on to a diagnostic evaluation. And that diagnostic evaluation could be a multi-phase CT or a contrast-enhanced MRI. And I think going to your point, if they have that diagnostic evaluation and they have characteristic appearance on the CT or the MRI, then you can make a diagnosis of HCC without doing a biopsy. And so that characteristic appearance, as you started to say, Richard, was arterial enhancement. So enhancement on the arterial phase, and then what we call delayed washout. So it's darker than the appearing liver, either on the portal venous phase or the delayed phase. And what we've seen is that you can actually make a diagnosis of HCC with about 95 to 97% specificity. So really good. However, we may have shot ourselves in the foot because now we have very little tissue on HCC, which has hampered our understanding of the cancer. And so you can make a case that part of, and you probably know this even better than I do, all of the failed clinical trials that we've seen are in part because we're stabbing in the dark instead of really saying that we have a good understanding of the tumor biology. And that may be hepatologist's fault because we've been making this diagnosis radiologically instead of pathologically.
This is like music to our ear, hearing from a hepatologist that they want tissue. That's fascinating. If we did this program 10 years ago, take my word, we'll be spending here half an hour discussing that subject, and it will be a great debate about if really we need to get tissue or no tissue. But to hear it from the hepatologist, that's really fascinating because it appears, in all fairness, we're all on the same page. We got to have the tissue because now what we're going to discuss next, not only from the diagnostic standpoint, but even from the biomarker standpoint and what kind of targets we're after, which we're going to cover in the next piece, which we're going to take pretty much most of the bulk of the rest of the program, which is systemic therapy. So with this said, and we're going to go back, of course, to this question. Richard, systemic therapy, obviously, we kind of dissected which patient are going to go on treatment. Reasonable performance status, we'll dissect that a little bit in detail. Not necessarily only metastatic disease, but maybe patients with local advanced disease, but not amenable to some form of local therapy, which is, of course, based on some discussion. Sorafenib has been the standard of care. It was, if anything, tested and reported and approved all in 2007. We've been 2007 to 2016 with an improvement survival by more than 10 months, 10.7 months to be specific, versus 7.9 for placebo. Clinically and statistically significant, one of the fastest approval of drugs in the FDA, and then the great lull from 2007 till now. What's going on?
Yes, it's been a little disappointing to say the least. And I think that none of us would have expected us to be here 10 years, almost 10 years later without another approved drug. But let's look at the drugs that have gone in the frontline setting at least, because still in the second line setting we don't have anything approved. But in the frontline setting, the majority of the drugs that went up against sorafenib were very similar compounds, right? There was sunitinib, there was brivinib, lenifinib, a lot of small molecules, multi-kinase inhibitors. And the decision to go forward was not based on strong data. Most of it was based on single-arm, small phase 2 studies. The combination of erlotinib and sorafenib, the SEARCH study, which was one of the first studies to go forward, had no real clinical data supporting it. So, when you take 40 patients and say we treated them all with a given agent and we get a survival that's 15 months or 16 months and say, hey, that's better than sorafenib's 10.7 months, then it's not that hard for people to convince themselves that they have something to move forward with. And all these studies were very, very large, at least 900 patients, some over 1,000, because they were looking at fairly small improvements. And they were not based on any strong biologic rationale. I think a lot of us looking back now could say some of those failures could have been limited by the idea of a randomized phase 2, at least, where we can get a signal of whether or not this is just patient selection or a real activity of a drug, as well as the idea that was touched on before is whether or not we can select patients with a given therapeutic that do better than others. Is there a biomarker for response? Still, I think with a lot of these multi-kinase therapies, it's going to be hard to identify that. And so far, most of the drugs that have gone forward in the frontline setting, and for that matter, in the second-line setting, have been empiric. We're now seeing that change a little bit. But to answer your question, I think a lot of us got too excited based on small phase 2 studies.
Fair enough, but nonetheless, and we're going to dissect a little bit into the future, because obviously, even though we have those negative studies, it does not imply that we're not going to try in different approaches. And we have fascinating data and fascinating thoughts that we're going to share with you in a minute. But let's go back to